So what are some pitfalls in torsion? Well, there's spontaneous detorsion. Again, if you have a bell clapper deformity, you can twist and untwist, and these kids will often have increased flow, which can be confusing. Intermittent torsion and then partial torsions. So a partial or an incomplete torsion is generally less than a 360-degree twist. And in these kids, you can have color flow, but it'll be less than on the asymptomatic side. And while your waveform may be changed, you can also have normal-looking arterial flow. So this child came in with acute scrotal pain, has an abnormal lie of the testis, okay, has this paratesticular mass, even has some microlithiasis, just for a bonus, has some surrounding hydrocele fluid, but if you turn on color Doppler, normal side has lots of flow, but this side also has arterial flow. And if you are in a practice where you just trust on that as a sole sign, you're going to miss this case. While I'm not going to show you the images, the waveforms were identical from side to side. So this child had a 360-degree twist and was salvageable at surgery, but if all you go on is just a binary decision of flow or no flow, you're going to miss these patients. Here's another child, less flow, but still we could get Dopplerable flow in the symptomatic left testis. Again, not a normal grayscale appearance, kind of an abnormal transverse lie. And here's the arterial waveform. Normal side on the left, abnormal side on the right. You can see reversal of flow and diastole, indicating venous congestion. I do not typically look for venous flow. I know a lot of people do, particularly in Europe. I haven't found it to be a great discriminator, but again, certainly this indicates congestion from occluded vessels before it goes on to have arterial occlusion and can be a useful sign. So detorsion, okay, typically you want to go counterclockwise. If you're standing at the foot of the bed, you want to rotate like an open book, and these pages from the internet show or these pictures from the internet show a dusky testis. Once it is unwrapped and the cord is no longer kinked, it pinks up and proves to be a viable testicle. Here's a case that occurred in our department. On the left, you can see this very young child, normal testicle. The left side here just has sort of color Doppler chatter within it, and manually detorsing this child, because it had been going on for about 6 hours, the operating room was going to be a little bit delayed, and you can see the tremendous increased blood flow after that detorsion. The child has immediate relief of pain. This child certainly needs an operation, but can at least afford to wait a few hours if need be, and ultrasound can prove that there now is flow to this testicle and that the surgical emergency is at least bedded for some time. Here's a corresponding nuclear medicine images showing the same thing in this child who is manually detorsed, showing increased blood flow to the previously torsed testicle. Now, intermittent torsion is something to be aware of, and I think it's very important that you have to ask the patient, whether adult or child, what's their degree of pain when you're doing the imaging. So this particular young teenage boy on the left came into our department several times over the course of 18 months. And every time, or the first 3 times, he had images like you see on the left there. So testicle was a little swollen, the epididymis was big, there was a reactive hydrocele, a little bit of hyperemia. And in one of the reports, it even mentions that the child had less pain at the time of examination than what had caused him to come to the emergency room. Now, this child received appropriate urologic follow-up, had appropriate testing, everything was negative. But the last time he had scrotal pain, he decided to stay away for a week, since they never really did anything for him in the emergency department. But unfortunately, this is what the testicle looked like when he came in at that time. And so now it's a completely dead necrotic testis. And I am sure that he was intermittently torsing, and we failed to pick up on the symptoms. So again, it's very important to consider the degree of pain. If they detorse, they will have relief of pain, and so it can look like an inflammatory condition, but in fact you've got a detorsed testis. Appendiceal torsion is the most common thing that we see in the prepubertal population. Generally, these are testicular appendages that twist. They live right next to the epididymal ones. You really can't tell the difference. And if you can faintly see as you stretch the skin over these infarcted appendices, you can see this faint blue dot, this discoloration beneath the thin scrotal skin. If you look for them, you will find them. They are almost always associated with a hydrocele. These can produce tremendous hyperemia. And in the literature, these are often called epididymitis. And while it is an inflammation of the epididymis, it is not epididymitis in the classic sense of being an infectious etiology. So in this particular case, a fairly typical appearance. You can see the torsed appendage. They often have this heterogeneous, described as salt and pepper appearance. They're typically over 5 millimeters with tremendous surrounding hyperemia. There's thickening of the scrotal skin, some dirty hydrocele fluid, and you can even get some associated testicular hyperemia, but tremendous inflammatory response. Most common thing we see in prepubertal males. Most of the time these will go away with just conservative treatment. Occasionally they need to be operated on to remove these. Here's just another case showing this torsed infarcted appendix with tremendous hyperemia in the scrotal wall and within the testicle. Again, most of the time they don't need to be operated on, but if the pain is not going away in a week, they will operate, they will lop off the torsed appendage, causing this tremendous inflammatory reaction of the adjacent epididymis. Later, as they shrink down, they will calcify into these little nubbins, okay, that you will see on later imaging, and these can actually float free within the scrotal sac and become these scrotal mice. One of my favorite clips in the world shows one of these flinging around loosely within the scrotal sac. So again, the diagnosis of torsion is no longer a binary decision. You have to consider the pain at the time of ultrasound. So if you have a patient who's got hyperemia and increased flow, and they have the same amount of pain they did as they came in, that's some sort of inflammatory condition. Those children do not need surgery. If they've got hyperemia, but they say, yeah, my pain is better, I don't feel as bad, you have to consider detorsion. And while that may not need surgery now, they may well need surgery later, and at the very least, very close follow-up. So just as a quick summary, for typical emergency conditions, vomiting child and pyloric stenosis, you have to move the patient. You may have to roll them up on their side to get fluid into that antrum, which is key at separating the antral walls and really defining the outlines of the true pylorus. If their stomach is too full, consider prone imaging. Look through the back to help see the pylorus, which may be displaced more posteriorly. Look for the SMA and SMV. While it is not a perfect test, you can often be a hero and make the first indication that this child may have malrotation with or without intermittent volvulus. Appendicitis is still the most common cause of emergent surgery in children. The graded compression technique and the use of color Dopplers and adjunct generally will lead to success in the vast majority of cases. In spite of the current popularity of CT, ultrasound is still a useful tool and should still be considered the first line in imaging in any child with with appendicitis. Intussusception, ultrasound has a very high sensitivity for finding intussusceptions. In pelvic pain, like in adults, ultrasound is the imaging modality of choice. Cysts are very common. Torsion is what we are really worried about many of the times, requires a high index of suspicion. Remember that Dopplerable waveforms are not completely reliable, and look at the difference between the two sizes of the ovaries. For pelvic pain and testicular torsion, remember that testicular torsion is not the most common thing, but it needs a rapid diagnosis, which is why we are called to image quite frequently. Appendiceal torsion is the most common diagnosis. Look at blood flow symmetry and consider the symptoms of the child when making your diagnosis. Thanks for your time. I hope that's been useful to you.